Yeah. So as I mentioned, I'm part of the BEST Center here, and myself and Dr. Kreider coordinate and run the Cognitive Behavioral Therapy for Psychosis program. And I'm hoping today in about 15 minutes to give you a kind of an overview and kind of an idea of what CBT for Psychosis is, a little bit about what CBT is, a little bit about how it's modified for psychosis. And then afterwards, talking just a little bit about kind of the team-based approach that we use for that, and then certainly leave it open for questions, kind of moving from there. So moving ahead here. So I think most folks on the call here on the Echo are familiar with CBT. It's a form of psychotherapy, probably the most common, maybe popular form of psychotherapy out there. Some of the essential features with CBT are therapeutic alliance. Sometimes CBT gets a bad rap in terms of being very technique oriented, but it really does focus on the relational connection with the person and building that as part of the therapy. CBT is very action oriented. It's educational, but it's action oriented and directive a bit in a way of helping people to discover and learn for themselves the patterns that kind of help in their life and the patterns that get in the way. Very client focused. There are feedback loops built into the structure of CBT that allows for kind of checking to see if you're on the right track, and also to kind of help the client shape the session. Formulation driven, I'll talk about that in a little bit, but it's really kind of this idea of we collect information to understand kind of patterns and understand how a person's life has developed in certain ways and how those patterns get maintained. And that guides the treatment. There's a set structure to sessions. It's time limited. Certainly use cognitive and behavioral strategies within it. And then you use homework as a mechanism to kind of help maintain and extend gains that are developed as part of the actual therapy session. So it's intended to be more than just a therapy hour, kind of intended to go beyond that. When most folks think about CBT, they often think about this sort of image. Sometimes we talk about the CBT triangle. And the reason we say it's transdiagnostic, it kind of comes from this idea that most any situation can be broken down into these basic elements, where something happens and we have thoughts about it, emotions related to it, and behaviors. And so this is an example of a formulation. So it's rather simple, but it kind of can help us break down any kind of situation. And just to kind of give an example, so if the situation where a person's coming in for loneliness and the situation is I've been invited to a social event, we can see how certain thoughts may affect that. If your automatic thought is, wow, that's great, I finally get to see somebody, I may feel some upliftedness about it and look forward to going. If my automatic thought to a social invite is, oh my gosh, it's COVID, we can't see anybody, I might get sick, I'll embarrass myself, there's likely to be more anxiety, and the behavior may be one that has to do more with avoidance. So we can begin to kind of see these kinds of patterns. And Aaron Beck, who really kind of developed this approach, identified that certain disorders come with certain kinds of thoughts. So if a person is depressed, there are categories of thoughts that are predictably there. Likewise for anxiety and for other things. I'm not going to go into a lot of detail, but a CBT therapist would begin with this simple formulation and then sort of build it out to better understand, kind of what leads to behavior, what affects people. So when we think about what is CBT for psychosis, what does that mean? It's all of the above, so it's CBT, but there are certain elements that make it a little bit different, and I'm going to go into these briefly, but going to try to go into these. Mindset of the clinician, engagement, acceptance, normalization, and then a little bit about the actual strategies. Now, when working with schizophrenia, one of the things that we kind of start with is that there is a lot of stigma associated with schizophrenia, and certainly with mental illness in general, there's stigma, but with schizophrenia, it's sort of at another level. In particular areas and ideas that folks have about dangerousness and in social distancing. What's kind of interesting is now with COVID, there's lots of stuff on social distancing, but when you look at the research from a few years ago, a lot of it had to do with mental health providers and other people's perceptions of those with mental illness, in particular schizophrenia, and the desire for social distance. And what we find for lay individuals, people in the public and mental health providers, there tends to be a greater concern about danger and a greater desire for social distance, even with mental health providers. And so being aware of what the mindset is really important. And so we start with the Schizophrenia Commission report, and this actually comes from an article by Brabin, and just kind of asking, what do folks with schizophrenia, what do they want in their treatment? What do the consumers want? So they really want to be listened to. They want to be seen as a person, be given hope. And then have their experiences validated is really important. And you'd say, well, of course, But you also have to remember that some of their experiences are things like the devil is attacking me, or I have a chip in my brain. And so, how do you validate that without, the word is colluding, kind of going into that too much, reinforcing, et cetera. So there are some, some skill elements here that need to be brought up. Individuals want more information and choice, more collaboration in treatment, and then regaining a sense of self and rebuilding their lives with optimism is really important. So one of the things that we do in our trainings and just in general is, what is the mindset of the clinician coming in? And, at the top, you'll see my little continuum 0 to 100. And, CBT folks use that a lot. I apologize, but I'll have a continuum up there a little bit so you can kind of use these. So one of the things is thinking about, is recovery even possible for someone with schizophrenia? And I'll have to say, when I did a lot of inpatient work and someone asked me what percentage of individuals recover with schizophrenia, in some of the harder moments, I'd say, I don't know, 15, 20%. And when I do trainings, clinicians will similarly report relatively low assumptions or beliefs about recovery. And if you look at the data, and you can maybe do a mental note for yourself, how many people with schizophrenia do you believe recover? The data points us more in the range of 60 to 80%, both in the US and actually a little higher in other countries. And for me at the time, that was like, wow. And so I really started to look into that. And the reason that's important is that depending upon our beliefs and assumptions, that'll affect kind of treatments we choose, how we approach a person. So it becomes important to understand how, where do I stand in terms of thinking about recovery? Other mindset things that are important are things like the understanding of the role that stress plays in psychosis and how very important it is, especially trauma. The idea that psychotic symptoms can be understandable within a person's life experience. And this is really important. And it's tied to the next bullet point around psychosis falling on a continuum of human experiences. The idea here is that a lot of times people, when they think about psychosis and they hear a symptom or a belief that seems very bizarre, you're like, wow, so that's otherworldly. That's somebody else. They're over there. And really, a lot of what the recovery movement and CBT has tried to do is say, no, it's not way over there. This is part of a continuum of human experience. And an easy example is paranoia. Any of us here in a particular place where we feel there's danger, it's dark, a neighborhood that's unfamiliar, will be, feeling a bit paranoid about that. And so we can link to that experience. But understanding that even more bizarre delusions start with a common human experience. And once you really get to know the person, they're typically understandable. Now, these assumptions I have listed actually come from a survey from Morrison. They surveyed experts in CBT, and they said, if you're going to do work in this area, you ought to look at these assumptions, and the mindset that you have ought to, have a sense of recovery. The stress is, important here. It's understandable, the idea of continuums. The other big adjustment for CBT for psychosis is practice modifications. And really there, it's more about being flexible with the structure. CBT is pretty structured, and they want you to follow the structure. With modifications for psychosis, there's a lot more room for flexibility with that. Okay. There are somewhat predictable phases in CBT, and I'm not going to hold this to rigidly, but we used to call this our soccer ball in our training manuals. But the idea is that there are kind of phases we go through, starting at the top of the circle there and kind of going clockwise, where you engage and you assess. You kind of help them make sense with the formulation, you improve daily living, move to consolidating skills, move to kind of staying well, those kinds of things. That's a typical pattern. On the outside of the circle are skills that you would use at those times: education, normalizing, using the cognitive models, strategies, involving with the community, et cetera. And at the center of the model is helping the individual develop a sense of agency and empowerment, and enhancing self-concept. How do they think about themselves? Because we found from the research that that's really important in mediating the experience of psychosis. All right, so that's the mindset. The next piece is engagement, which I've alluded to a little bit. And starting here, again, there's the idea that there could be a gap in perspective. So someone coming in may be forced in to see you. And when they're there, they may come from the perspective of I'm not ill, why should I trust you? And then on the other side of this wall is the provider family saying, hey, you need help, trust me. And so there's a gap there. And so what we try to do with CBT for psychosis is bridge that gap. And how we do that is trying to find the common ground. And how we do that is by something that the UK really coined, this idea of befriending. And in the United States, the Beck group has really talked about how to help the person find their adaptive mode. And so that's really about spending a lot of front end time on what's your strengths, what's important to you, what do you value, what do you want to do in your life? Let me get to know that part, trying to find that energy and interest. And when they're at their best, That's kind of like we begin, start with what's strong, not what's wrong. All right. And that's really important from a confidence and a trust standpoint. And then once we find that, then we kind of move forward. So we spend a lot more time there than we might in other kind of forms of therapy. All right. So befriending and engagement. Acceptance. So now we're not saying acceptance in terms of like, yeah, of course the devil's after you, that kind of acceptance, but we're talking about the idea that we don't have to eliminate symptoms in order to have a quality life. All right. We start with a person, just as I was saying, begin with a relationship. The idea is not to like, we got to get your voices away, or, you have to realize you're paranoid and get rid of that. It's really about what do you want to do in your life? And then what gets in the way of it. All right. And usually what gets in the way of it are symptoms. So I want to have a job. I want to get married. I want to do things. Okay, let's start. Where are your strengths? How are you getting there? What gets in the way? And so then what gets in the way can be things like voices and delusions. And then it gives you more permission to work on those things. In the early literature, they talked about coming in through the back door. So it's not like we got to reduce your hallucinations. It's more, we got to get you working and having a relationship. And then we can work on hallucinations as part of that if that's getting in the way. The other part of acceptance is starting to explore the symptoms from a place of neutrality and curiosity. So if someone says they have a chip in their brain, it's not like, well, that's not possible, and let's look at the data. It's more like, well, can I understand more about that? I don't fully understand it. Let me see if I can understand it. And I heard Aaron Beck give a lecture on it, and he said, sometimes the idea here is you almost have to step into their world a little bit and their experience, join them there, and then invite them to step into another space, into your space. But you got to join them in that space first, just to understand. Not to say, I agree with you, this is happening, but let me see if I understand what your experience is, and let's see if we can understand this maybe in multiple ways. All right, so engagement, acceptance. Normalization is a strategy used in other parts of CBT, but it's used quite a bit in CBT for psychosis. And the idea here is to help a person feel okay-ish, safer to talk about topics. So something like voice hearing. At one point we were like, oh my gosh, if I'm hearing voices, I'm crazy, I go to the hospital. So how do we create a space that's safe to have that conversation? And that's where normalization comes in. And that's where we talk about commonness of experience, how common certain experiences are in particular, but also, some personal self-disclosure can come up as part of a normalization process as well. And before I go on to the commonness of experience, just a little bit about personal disclosure. It's not saying that you talk a lot about your life and get into a focus on what your issues are. It's really more about where do we have common human experiences. So I had a client once say to me, gosh, I can't stay focused in session. I lose track of things. Does that ever happen? My response is, yeah, there are times when I'm tired or even when I'm focused, I need to take notes and remember this is a common human experience we both can experience. All right. Kind of that sense that, as human beings, we have certain kinds of experiences. Or if I miss sleep, I have a really bad night's sleep or I just don't get much sleep, I don't think as well. My, cognitively, I'm off balance. And that's, true for just about any of us. So that's another way that you can normalize. The more, I don't want to say technical, but when you're sharing information, you may say, 8% of the normal population, 8% of folks can hear voices. And folks that hear voice one time, especially hearing their name, that can be up to 10, 20, 30%, depending upon the survey. So it's not that otherworldly of an experience. And in addition to that, there's some famous folks who hear voices, Brian Wilson, Anthony Hopkins, and there's a whole list of them we could share just to kind of normalize, hey, other people have this experience and, go on to do things in their life. Voice hearing is also more common under stressful situations, grief, things like that. So again, that gives you a little bit of room then to talk about, well, yeah, did you know when people are grieving, they can hear voices or see things, or when they have trauma. So then it creates opportunities for conversations. The other piece, the biggest probably normalizing element, again, as I said before, is stress. And we go into some detail talking about the stress vulnerability model and that all of us under enough stress will show some kind of symptoms or some sort of distress. And those symptoms and that distress directly relates to whatever our vulnerabilities are, our biology, our previous life experiences. And so it's kind of making their experience on par with every other kind of experience where they may be having symptoms or distress. It also creates a model where you can talk about protective factors and risk factors and how do we strengthen your protective factors and minimize your risk factors. So it's less about you're ill and you need help and more about, hey, we all can struggle with stress and our vulnerabilities. What are some ways we can maximize our potentials and reduce our risks? The complicating factor with psychosis, as I alluded to a little bit, is the lack of awareness or lack of insight. And the differentiation we make is between denial and sort of more of a neurological basis. And so psychological denial is you have awareness, but you're avoiding whatever it is because it leads to some distress. With psychosis, and particularly schizophrenia, there's a fair amount of data that supports this idea of anosognosia, which Javier Amador and other authors have talked about. And it's the idea that the lack of awareness of things is rooted in some kind of more of a neurological brain chemistry piece and less about denial. And when that happens is that individuals, they have a reduced capacity for self-reflection, difficulty understanding the mindset of others, viewing things from multiple perspectives, the stuff we refer to as metacognitive sort of information. So when I worked inpatient, people would come in who hadn't showered for months and looked visibly just very distressed. And they would say, I'm fine, I just showered. And, they would just, and it wasn't a psychological denial, it was more this processing piece that was happening. And the reason that's important is then we then discuss working around it as opposed to being annoyed by it as a, let's say, personality factor. So that's the piece on normalization. So, and then the other piece we work on is specifically working on these cognitive and metacognitive skills. One way is through sharing the formulation. So helping people see how their thoughts lead to emotions and behaviors and helping them to understand in a personal way how their experiences may have developed. In even psychotic, delusional sorts of experiences, making sense of it with them, all the while helping them expand their kind of cognitive perspective and metacognitive perspective. So an example of that would be with voice hearing. A common approach might be, the voices say you're the worst person in the world, you're terrible. And one approach would be to say, is that really true? Looking at the evidence. And they would say, yeah, that really isn't true. And so that would be a cognitive piece like, okay, yeah, that part's not true. There are some good parts to me. And so that's breaking apart the inaccuracy of what the voices are saying. And then the metacognitive skill would be, so what does that say about the voices? Are they right all the time? Or could this be inaccurate that we made to think about? So the metacognitive belief is like how right or how powerful are the voices? And then that you sort of prime them for that self-reflection, and then you sort of help them look at it at two levels, like, yeah, they are inaccurate and they may not know everything. And we need to do that kind of specifically and repetitively to kind of help them integrate that information to help with the metacognitive difficulties. And likewise with the action-oriented learning, even the behavioral skills of like trying things and doing them, helping them to reflect, like, you didn't really think you'd enjoy that puzzle we worked on. How much are you enjoying it while you're doing it? Yeah, I'm really enjoying it. Okay, well, what does that say? Well, yeah, when we anticipate things, it may actually turn out to be better than we thought, so helping them with those kind of self-reflection skills as well, helping them build a schedule, et cetera. I'm just a quick note on the third wave approach, which is really kind of mindfulness, compassion focused therapy. This is developing some traction in the CBT world. And from a mindfulness standpoint, and again, I'm not an expert here, but part of the idea is when I get a sensory experience, to not react to it, but to notice it. Just notice there it is. And I notice that it's there and it is an experience and it's not affecting me in any physical way, but I'm just going to notice it and redirect my attention to other things would be one example of using a mindfulness kind of strategy when it comes to psychosis. And I'm not going to go into more detail because they're pretty much in depth to get into that stuff in more detail. And I'm almost out of time. Two more little bits. There are levels of CBT for psychosis care. So on the bottom right quadrant is the high intensity, and that's your traditional therapist version. But what we're training is other individuals. So there's low intensity CBT, so psychiatrists and other nurse practitioners and other folks who aren't going to do the full formulation thing can develop skills and strategies in this approach. And at the CBT informed care, case managers, peer specialists, family members can learn skills along these lines to interact more effectively with family members. If it's a family member or, case managers on the front line who have 15 or 20 minutes, how can they work in a way that's informed by this approach to be helpful? And then there's, of course, group variations of it. And then the final piece is that CBT for psychosis is really, in my view, integrated team approach, a little bit more like DBT, dialectical behavior therapy, where it really takes a team. The person is in the center with their strengths and their vulnerabilities, and then there are services around that kind of support them. And Ron Unger, who does training in this, he has a nice metaphor. He's like, if a person is experiencing the throes of psychosis, it's like they're in ice water. And if you're doing that, trying to help them out of the ice water by yourself, it can feel very daunting. But if you got a team that are on your arms and shoulders and helping you, you're not alone. You have more support in being able to kind of do that. All right. And it's also more holistic that way too, and a better way to kind of integrate them into the community. So anyway, that's my pitch for more of an integrated full team approach. And I'll take certainly questions, but just to kind of highlight, there are a couple links that I included for you guys. The North America CBT for Psychosis Network is a brand new network in North America, and it's for providers who are doing this work, and there are resources, training opportunities, et cetera there, and that's a sort of North America-centric kind of thing. Encourage you to look at that, and then a couple other websites. Strong 365 is a good one, generic one, general one to kind of look at. And then my references, and then I have a list of manuals in the back that you can look at as well. So, any